So welcome you all for the 22nd edition of the Peculiar Case Series in Renal Transplant. As we defy nature and do transplants more and more, we often face onslaught of nature, actually. Nature fury was sometimes very too much for us to deal with. The problem is how to deal with this kind of onslaught. There is no written protocols anywhere. Many times we are left with nowhere. So this platform, which was combinedly organized by us, myself and Dr. Vel Arvind, 2 years back, couple of years back, has gone miles and leap and bounds and attained the stage of one of the intellectual platforms in nephrology in India. So every month we are conducting this program, and this program has no means of inferior to others. As always, we have two interesting presentations of renal transplant complications, which being paneled by the eminent panelist. I am privileged and proud to welcome Dr. Santosh Varghese, who is not new and doesn't need any introduction. Still, I have a privilege to introduce him as a rotatory unit head of rotatory professor of CMC Vellore. There is a policy of rotatory headship in CMC Vellore. He was head of Department of Nephrology and is presently heading the Unit 2 of Nephrology. And he is the he has many non-academic portfolios like ISN. He is holding a top rank in International Society of Nephrology and the Indian Society of Nephrology. He's a peer reviewer for many journals, and he has trained a lot of nephrologists from CMC Vellore. And Sarah has a lot of experience in renal transplant and its complication, especially we expect more from him in this forum. And joining him is Dr. Narayanan. He's from Pondicherry, and he did his DM from IKDRC, Gujarat, 20 years of vast experience in nephrology. And he is supposed to be one of the early nephrologist of Pondicherry, has a lot of around 2 lakhs dialysis, hemodialysis till now. And he's a director of Lakshmi Narayana Medical College in Pondicherry and Kidney Care Center. He's chairman and director of Kidney Care Hospital in Pondicherry. Has a lot of transplant exposure during his residency and after his practice also. And not the least, I am very much privileged and happy to welcome Dr. Mohammad Iqte sir, and who is a vice chairman of the Mujlibai Patel Nephrourology Institute at Nadir. I had a privilege of visiting the institute in my DM residency time, and we used to see a lot like a mini transplant factory next to IKDRC in India. And Sad is a voracious academician and voracious reader, and I could able to I have a privilege of attending his rounds during my residency time also. He has trained around 50 nephrologists over, and he is editorial board of scientific committee of IS and Indian Society of Nephrology. Welcome you, sir, for this platform. And we have two speakers. One, Dr. Vel Arvind, and he's my colleague. And if you have one post like surgical nephrologist, he's a torchbearer actually. And he has around more than 1,500 transplants of his credit. And I apologize if numbers are wrong. And you name any complication in renal transplant, you would have faced it and you would have managed it. He's an academician and he's very interested in teaching. And together we brought this forum, and this forum is kept alive because of his bubbling work. And even though after 21 years of nephrology experience, he still work as a postgraduate, or what I feel actually. Like interest and passion towards nephrology is going day by day as he grew older. Welcome you, sir. He will be talking on them. Some of the interesting complications, and which I will be revealed during his presentation only. And I'm very much happy and privileged to welcome Dr. Shirapani Gopulini. And on the reading CVS, I was mesmerized that he is one of the peer reviewer for CJASM, and he has been working in UK for past 15 years. He's in Cambridge, Oxford, everywhere, and he has been the one of the peer reviewer for many journals actually. And he has a lot of 45 publications to his credit. And he has interest in CD4 helper T cells. And his center, Cambridge, is known for the many trials in ANCA vasculitis, many trials like that. And he is also a part of many of the world-class trials in Cambridge. And he has recently come to India, and he's working as a nephrologist at the Citizen Hospital of Hyderabad. And he has a very good case from his armory, and he's going to present his first case, that is unblocking hypertension. Welcome, Dr.
Thank you.
Thank you. Without wasting much of the time, let me go to the presentation, and I invite Upalani to share his slides and start his presentation.
Thank you, Dr. Rajan, for that introduction. I'm privileged to be amongst the most eminent nephrologists in India. And I'm sure this is the gateway to a great partnership in the future. So I'm just going to present this case, which I titled as Unblocking Hypertension. I hope you can see my slides.
Yeah.
Okay, so I'll just dive straight into the case here. So this relates to a 32-year-old male patient. So he's got end-stage renal failure, unknown cause. He's in the background, he's also known to be hypertensive. He's got a dialysis vintage of about 6 years. At the time of transplantation, he was completely anuric. He was dialyzing 3 times a week in a peripheral center. So he used to only come once or twice in a year just to make sure that he remains active on the transplant wait list, which in Telangana is known as Jeevandan program. So the clinical course of this patient is he's had an offer in the middle of the night. A donor, a 26-year-old female, died of subarachnoid hemorrhage, no other known comorbidities. The mismatch was 1-to-1. The donor warm ischemia time was about 10 minutes, and the recipient warm ischemia time was about 45 minutes during surgery. In between, the cold ischemia time was about 4 hours by the time we got it to our center, and then started the process. He received the standard induction therapy with basiliximab, along with methylprednisolone induction. He was started on tacrolimus, mycophenolate, and prednisolone for maintenance therapy. He also received prophylaxis with Subtran and Valgan cyclovine. So the clinical course was slightly complicated. I mean, having just landed from the UK, I had never used Arcamine. There is clonidine. Okay, so I am naive to the after effects or withdrawal effects of clonidine. So the first night itself, I had almost close to a heart attack where his blood pressure shot up to 200 systolic, and he was severely tachycardic, perspirating all over. So at the time, that night, I had a masterclass in clonidine withdrawal. Anyway, so we managed to give him some clonidine and bring his blood pressure down pretty rapidly and swiftly. Subsequently, blood pressure was under pretty good control, and he was maintained on clonidine and cilnidipine. Now, given my experience, I would have gone for prazosin rather than cilnidipine now. And then, as expected, he had delayed graft function. So he had a biopsy at day 7 as per the usual practice to make sure there is no ongoing rejection. This ruled out rejection and just showed features of ATN. So he was discharged home on dialysis. Day 12, he's still not opened up, relatively anuric. In the financial constraint that we had, I repeated his Luminex DSA, and that was negative. So we continued with dialysis and maintained him on tax, mycophenolate, and prednisolone. So day 14, glad he started making urine, and then a rapid drop in his creatinine followed that. By day 18, his creatinine was 1.2. So we're all happy that things went well and no issues at this point. And tacrolimus levels were adequate between 8 and 9. So prednisolone dose was started to be weaned down, and by day 21, it is on 15 milligrams. So, and then this is a chart. At the bottom, you can see the days labeled from day 1 to day 65. And these are the blood pressures. The blue is systolic and the red is diastolic. So the first nightmare I had was day 1. when it was clonidine withdrawal. So it was pretty relatively simple and straightforward, and I became more knowledgeable on clonidine. And then blood pressures were perfectly fine until day 17 or so. And then on day 21, he presents very, very breathless and a blood pressure again of 225. So I checked with him, are you taking clonidine? You haven't missed it, right? He says, no, I've been taking it without missing. And then I wasn't certain what was happening. So and then what did I do? But he's also had breathlessness and headaches. So at this point, we got an urgent ultrasound because what is happening? His graft function, his creatinine has remained reasonably stable with a creatinine of 1.2. So this is the ultrasound at the time. The peak systolic velocities, which is this particular area where this is focusing, is the proximal part of the main renal artery. And this scale, unfortunately, doesn't have any readings on it, but this is the upper scale is about 350. So the peak systolic velocities were recorded to be more than 3.5 meters per second. And then in the intersegmental arteries, you could see this parva status, and also the acceleration times were prolonged. As you can see, the acceleration time was 0.12 seconds, and the resistive index was actually quite low at 0.46. These strongly suggest the possibility of renal artery stenosis. But hang on, I have never, having worked in these other centers in the UK, I never seen renal artery stenosis within the first 3 weeks, that too presenting with such severe symptoms. He was hypoxic, breathless, headaches, and in a pretty bad shape. So we went on to do a CT renal angio. This is the external iliac, as you can see, and this is the transplant artery arising, and this seems to be the problem area. I'll just play this video of a reconstructed 3D CT. So as you can see, this is the external iliac artery. This is the renal artery, and that is the tight stenosis that we were able to identify. Okay. At this point, the primary dilemmas I had were, okay, well, this is only 3 weeks down the line. Is this just perianastomotic edema? Will it just go away if I close my eyes and worry not? Can this be managed conservatively? So just by adding in more and more antihypertensives. But would conservative management lead to acute decompensated state and harm the patient? With blood pressures going as high as 250, 260, and diastolics like 140, 150, am I just going to just manage this, or is there any chance even of managing this conservatively? Okay, what's the safety of angioplasty stenting this early on? It's just like 3 weeks. And then is the anastomosis even healed? What about the integrity of the anastomosis? What's the risk of rupture? So then I started looking around. I didn't have the luck of having this group at the time, so I was doing everything on my own. And a little bit of help from my colleagues in Hyderabad. So the first thing I did was, increase the clonidine a little bit, and then added prazosin to try and counteract the alpha constricting activity of clonidine. Added metoprolol, which probably I wouldn't do now. And then given that renal artery stenosis is a condition associated with exaggerated renin-angiotensin-aldosterone system and retention of the sodium, so I added the thiazide, which seems to have worked temporarily, so there is some stability in the blood pressure. However, this was followed by severe hyponatremia, where this sodium dropped to 115. So I was in this situation where this patient is almost like a pressure cooker. We are adding more and more medications with very limited response. Each agent is for addition of a new agent is followed by a transient drop in the blood pressure, and then only for it to rise again. And then at this point, So some of the literature review that I did at that point. So just holding a break, breaking out from the clinical presentation, I want to briefly talk about what this renal artery stenosis is in the context of transplant. So when to suspect, what are the diagnostic criteria that have been in place to think of this condition. So if anyone who is suffering from one or more of the following three symptoms, we could and should suspect transplant renal artery stenosis. So there is an increase in the serum creatinine or a decline in allograft function for unknown reasons. So you have excluded most of the other causes for these increase in the creatinine. A patient who presents with refractory hypertension for unknown reason, you should suspect TRAS, or a decrease in urine volume or fluid retention for unknown reasons, then I think you should suspect renal artery stenosis. So the diagnostic criteria, these are not standardized. These are what some of the authors have described. If you have anyone with a graft artery peak systolic velocity more than 2.5 meters per second, and or a resistive index of intersegmental arteries less than 0.5. So the patient in question had both of this. The graft peak systolic velocity was like more than 3.5 meters per second, and the RI was 0.42. So what are the risk factors that may be associated with transplant renal artery stenosis? So the literature seems to suggest early TRAS is usually associated with some surgical complications, arterial injuries during harvesting, transplantation, clamping, torsion, or kinking of the arteries, or improper suturing. These may be the causes for early renal artery stenosis. And then late TRAs, which we are more familiar with or associated with atherosclerosis, contentiously CMV infection has been implicated, drug toxicity, immune responses. But I don't think there is one specific cause or condition that has been, other than atherosclerosis, has been conclusively shown to cause transplant renal artery stenosis. So also there is some suggestion that site of stenosis may give us a clue. Stenosis at anastomosis may be correlated with surgical techniques, whilst post-anastomotic stenosis may be associated with also de novo class 2 donor-specific activity. So in our case, it is very close to the anastomosis. So what else do we know? What is the published literature? So this article is from Eastern China, where interestingly, they haven't given how many patients they looked up. This is over a period of 4 years. They have recorded 16 patients who had early transplant renal artery stenosis, and their early is the median of 47.5 days after transplantation. 9 cases manifested with anastomotic stenosis, which they think are surgical related. 7 cases showed post-anastomotic graft artery stenosis, and they have also graded a third of, about 20% of them are mild, and then another 20% are moderate, and majority were having severe stenosis. And they showed that each of these patients following intervention had a definite improvement in the serum creatinines and eGFR. And also on the right-hand side, you can see when compared with controls, these patients had a very high peak systolic velocities and a low resistive index. And also there is a systematic review of outcomes following percutaneous angioplasty and stenting in the treatment of transplant renal artery stenosis, published in 2015. This does not differentiate the patient between early and late, and most of these are after 3 months to 6 months of after having transplantation. And I was primarily looking at this to understand what are the risks, and especially in the context of this early on kidney transplantation. So the primary worry with this is the vessel dissection, which constitutes up to 25% of the overall complications. And there are a few others like puncture site hematomas, vessel thrombosis, or malposition or migrated stents. So with this background, then we decided, it looks like this patient is going to decline or deteriorate whatever we do. Either we save him by removing the kidney or doing something about the kidney, or take the extreme risk. So the primary worry at this point is vessel, the anastomotic integrity at three weeks. So, well, with quite a lot of support from the surgical team, with the anesthetic team, and the interventional radiology team that included our cardiologist, we proceeded to go ahead with this angioplasty. So we also had bigger balloons to cause tamponade and block the iliac vessels in case of vessel rupture, so that we'll have time to shift him immediately to theater and get on with either surgical correction if at all possible, or at least to try and save the patient. So this is the angiography, and you can see this is the external iliac artery, and it's almost like a pinhole. And then we used a 4mm balloon and then angioplastied it with pretty good effect. And straight away, he had this stenting done here. There's a rapid drop in his blood pressure. And then I realized that, at this point, because thiazide caused hyponatremia, I stopped it. And given his blood pressure has been quite decent, I have chosen or been a little reluctant to put him on Lasix or a diuretic, but his blood pressure started to creep up again. And then subsequently, we added Lasix, and that has solved the problem. And his blood pressure ever since has been pretty decent. Through this entire course, his creatinine has not budged much. His creatinine has remained relatively stable around 1.2, 1.3. And after stenting, only we realized that that kidney was capable of achieving 0.8 creatinine. And with that, I just want to conclude my talk, and I want to thank these people who played an enormous role in solving this patient's problem. Thank you.
Thank you, Dr. Unni. It's a good presentation of the cases, and the management is very well done. And that is, you have gone through the literatures. It is very informative for us. One question to the respective panelists: that second presentation is also regarding transplant renal artery stenosis. Shall we have the presentation and have the discussion later, or we have the discussion after this?
Whichever is comfortable.
So what do you say?
We can finish it and we can both.
Okay, sir. So I invite Dr. Vel Arvind to start his presentation. We shall have a discussion after this presentation.
Raj, is it okay?
Yeah. Yes, sir. Yes, sir. Make it as a slideshow, sir. Yeah.
Yeah, is it
Okay,
okay now? Can you? Yeah.
Yes.
Is it a full screen?
Yes, yes. Full screen.
Okay. Thanks, Raj, for your very friendly words. And we have been together for many years, and we have been, and we discuss each other with some of because we are working in the same institute. We face similar situations, and you have been a very help all these days. And just moved by your words you spoke in the beginning. This is the extension of Dr. Pani has presented, and this I had 5 cases. Initial 15 slides will be about a preamble about the transplant renal artery stenosis, and this is the thing I just stress on any high volume transplant centers. The discharge book should have all these findings sort of for a quick reference for the future. This is about the aid memoir, I call it. The native disease of the recipient and the SNP of the TAC, induction agents, preoperative findings, and immediate 15 days post-operative, and of course the immunological workup, which is the mainstay of any transplant in a program. And this is the donor details and name and relationship and age, gender, and renal angio details like right and left, how many arteries are there, which side we chose, and a donor biopsy if need be. In some cases we do, and with that also report we attached with the recipient discharge dossier. So sometimes we have a single artery, multiple arteries. In one of my presentation here, I'm going to present one case, and the radiologist had a doubt actually where it was anastomosed and whether it had a polar artery. So if you have a high suspicion about transplant renal artery stenosis, you have to provide all the details to radiologists to aid them to come to a conclusion. Then we can devise a plan quickly according to the report. Otherwise, even CT might give a wrong report sometimes, because this information is to be provided to the radiologist in a complete manner. So this is about the recipient renal anastomosis, how many arteries, single, double, multiple, whether it is single artery anastomosis, internal iliac or external iliac, double if the pantaloon is made, or different anastomosis was made. All this detail, if this chart depicts about the preoperative findings of any recipient, donor, ureter, single moiety, double moiety, digestion kept or not, and in the one last line, you can whether digestion removal date also you can mention. So with this detail, if you have a strong highly resistant hypertension, fluid retentive state, graft dysfunction, if you provide this chart to the radiologist, it might be a very helpful to them to come to a conclusion quickly. So graft dysfunction is my own riot is the rejection, infection, obstruction are always, because more and more we do transplant, the complications also we face a lot, and TRAS is the 70% of the any vascular complication. This is the commonest one, and it is a potentially curable. And if you timely diagnose and intervene, and results are amazing. So I always keep now in mind and TRAS as one of the DD in any patient with the graft dysfunction. When all other causes are ruled out, especially high BP, fluid retentive state, I often mention the bit, and Pani also said, any fluid retentive state in a rising blood pressure with the graft dysfunction, I think TRAS should be kept in mind as one of the DD. And if even after sometimes 6 months, 7 months later, if a CME, chronic rejection also can put post anastomosis, the management is going to be similar to that of the routine TRAS, like stenting. So TRAS can be of early and late, and if it is 3 to 24 months, we call it early, and it's more than 24 months, we call late. And early technical etiology is the commonest one, like a suture material, whether cannulation of the graft artery while perfusion, whether it was damaged the endothelium, and whether they spatulate or anastomose without any spatulation, whether they choose the internal iliac artery or external iliac, all these things matters, but this is the purely technical. 70 to 80% of the time it is a technical one. Sometimes if it is a redundancy is there, especially if you anastomose the internal iliac artery, and that kink also can promote later TRAS. And if you diagnose and the response will be revascularization, will give an amazing result. Late is atherosclerotic, multifactorial, response may not be profound. So in any given case of TRAS before intervention, and we have to assess the salvageability of the graft. That one slide I'm going to show a little later. Sorry. It's not moving. Yeah. So when to suspect? In a conclusion, any refractory hypertension, creeping rise of creatinine, fluid retentive state along with rising blood pressure, acute graft function, dysfunction after ACE inhibitor ARB, escape any sympathetic crashing, acute pulmonary edema, otherwise known as a flash pulmonary edema. In that, the sympathetic system will activated, which again causes afterload. Is a vicious cycle will go on. This is called escape. And post-transplant erythrocytosis, some authors believe that it could be due to TRAS. And sometimes graft bruit, it's a very non-specific. Already patient undergone some any kind of a biopsy. This also can produce a bruit. So bruit is very non-specific, but it's a progressive bruit. If you watch a graft regularly on a regular basis, if a new onset of bruit, if it gives importance and points towards any TRAS, underlying TRAS. So if you see, basically, I run a transplant follow-up on 2 days in a week, Tuesday and Friday. Every single case, just put a probe and see how the Doppler pattern is. So it's a very important. Every nephrologist, so doing high volume and not dependent on radiologists. We ourselves can have some kind of very simple. It takes very few minutes to attend on a patient with ultrasound. Over the time, we learn quickly. The learning curve is very short. So this is the upstream, stenotic, and downstream, and many points were alluded to by Dr. Pani. The upstream is the high resistance. We do it in iliac vessel or an aorta in a native kidney. In a stenotic site, we call it a peak systolic velocity, which is more than 180 or 200 per second. And downstream, we see in an intersegmental or intraparenchymal, we TARDIS parvus, the RI. That's typically it's less than 0.5. So this is what the angle. I'm not going to detail all these things. So the probe and the insunation should be parallel to the vessel's intragating vessel, and that intragating gate should be adequate. It not be too large, not be too small. If you find any less spectral flow, color flow in a graft, you can widen the gate It should not be widened too much, because otherwise a broader spectral broadening will confuse. Because the post-stenotic spectral broadening is one of the diagnostic point of TRAS. But if you have if your gate is larger, then it may confuse with your real clinical findings. So this basic finds one should know before attempting on any graft with ultrasound examination. So this is what you see, that is a color Doppler ultrasound. It's a direct sign, indirect sign, a graft hilar artery. But that any from anastomosis to first branch, we call it as the graft hilar artery. It's though it is operator dependent, but over the time we can catch, and we should have a knowledge about whether it is anastomosis to the internal iliac or external iliac. External iliac anastomosis is very easy to catch, but internal iliac artery anastomosis is very difficult, especially in obese patient. But with the time being spent more than 30 minutes, and you can easily identify by putting both power and color, and you can trace that. At least you can catch the renal graft hilar artery. You can put up a gate and see whether the peak systolic velocity is more than 180. The indirect signs are the one, sometimes patients having long-standing renal obstructive stenosis, graft artery stenosis. It will reflect only by indirect signs like an acceleration time more than 70 milliseconds, a loss of early systolic peak, and parvus et tardus pattern, which is typically of a complete more than 90% stenosis. So this is what the documentation. Once you suspect, because many times we don't see such patients, but if you see any suspected patients, you make a special chart for them, because the first sign is the clinical suspicion, then ultrasound screening, confirmation by CT, then intervention. So for the right side, the graft size, CMD, because these two indicates whether salvageability could be of any use. And pelvic calcium dilatation, because obstruction always to be ruled out. Doppler studies, resistive index, pulsatility index, end diastolic volume. It should be done in the both upper, middle, and the lower. And hilar peak systolic velocity, iliac peak systolic velocity and its ratio, any spectral widening, and early systolic notch or early systolic peak, otherwise known as acceleration time, and spectral pattern like normal or parvus et tardus. Simple eyeball assessment will give a lot of idea. And so this, any suspected patient, this chart should be maintained and it should be followed. So now I just show you a few normal. Then with this preamble, I'll go into cases. I'll finish quickly one by one. I'm not going to detail every minute detail about the cases, but I'll give a salient feature about 5 cases. This is a normal one. And if you put a probe on the iliac vessel, you have a high resistance. You will have a peak, narrow based and tapering, most around 80 to 110 milliseconds per centimeter per second. Then you have a down deflection, which indicates the high resistance. Then the second one is the normal hilar PSV, and here the last one shows the. Let me just explain with. Okay, just give me 1 second. I'll go with the. So this one. So this area. So this is the where you can find out acceleration time, 48 seconds. When you measure the acceleration time, the first systolic notch should be taken as the first systolic peak. Sometimes we have a double notch, and that should be the first notch should be taken as for measuring the acceleration time. And I'll give you 1 or 2 slides later. It will come. I'll give you more details about that. So this is about the another normal findings in the hilar artery. A typical the pattern is about no diastolic cutoff, and this once you get acquainted with this kind of things, and the normal velocity is about 47.5 centimeter per centimeter per second. This is a normal pattern. This is one should, there is a sound also. If you have a this will give a lot of idea about this. Another patient, and smooth systolic diastolic. The sound will give a lot of idea about whether we are dealing with any sharp raise. Will have a whoosh, whoosh, that sound. The diastolic cutoff will be there. So sound will give a lot of idea along with your visual interpretation. So this is another case, intraparenchymal, the normal pattern. This is all normal pattern. Sometimes you may see a double peak, and the first peak should be taken for the acceleration time. And these are Any TRAS, the recommended treatment is the percutaneous transluminal angioplasty with stenting. It is no doubt about it. Predictors of kidney salvageability are kidney size more than 9 centimeter, good CMD, favorable histology. Suppose we are in doubt, you can take a biopsy. You can find out there's too much of FIFTA, more than 70%. There is no point in salvaging the kidney. At least we have to accept and go. And the time of intervention from the diagnosis, longer the duration, I think the poorer the outcome. So this predicting ability should have before, because it's all costly issues, and we may put patient at stake and life-threatening treatment like an open surgery, and also salvageability should be assessed before attempting on these patients. So technical success and clinical success both must be aimed at in any given patient. Many times we'll technically will succeed, but clinical outcome may not be good. So for that, the salvageability factors must be taken into account, and that should be borne in mind before giving a proper clinical success, though technical success is always possible with this modern gadgets and the expert around us. So sorry, it's not moving. Sorry, Raj, I just it's not moving. Okay. Yeah. Okay. Fine.
Yeah.
So surgery, stenosis at the anastomotic site, it's sometimes very difficult to negotiate. And King's severe stenosis inaccessible to PTA or failed PTA, recurrent lesions, surgery has to be considered. It's a final salvage procedure when no other options are available. But I'll tell you, surgery is a highly morbid surgery. Many times we lose the graft. So this, yeah, find some difficulty. Okay, so the another point is, this is the last point about my theory, then we'll go into cases. Would an angiogram be carried out on a recipient with a refractory hypertension and Doppler findings suggest of TRAS without any graft dysfunction? This I leave it to you, because the individualization should be required and everything should be customized according to the patient need and your clinical judgment, because we are the one, the person who's attending the patient have been following up. So they have to decide rather than going by the textbook knowledge. One has to have a practical knowledge in that particular patient. So first case. So this is the patient that we had in 2021, a transplant day, mother to son. Surgery went off well, and our practice is to anastomosis the internal iliac artery always. Predominantly our anastomosis is the internal iliac artery, and the surgery was in 3rd month, 6th month follow-up. It was a normal intraparenchymal pattern. I always draw a diagram as soon as the surgery is over so that I can have some idea about it. So this is what we made anastomosis the internal. Many times we ourselves we present inside the theater, we know where the kink is. So as the kidney was placed, and I'll just make a memory of it and I immediately draw a diagram so that it will help me to have an idea and future reference. So this patient visited after some time, because he was from distance, he was following with the local nephrologist. Mild leg edema, very high blood pressure, 210 by 110, requiring 3 or 4 drugs. From this time, creatinine was 3.8. The TRAS was in mind because based on the past clinical experience, but the ultrasound finding was not that clear. So I just asked him to use some kind of diuretics and augmented the dose of antihypertensive weighted. So it is a triad actually, difficult to control blood pressure, peripheral edema, with or without flash pulmonary edema, graft dysfunction, and this should come in mind. So after 4 months in August, we did a transplant March. In the month of August, he came with this kind of intrapanel, typical Parvus tardus pattern. There is very little color Doppler flow inside the graft. Blood pressure was uncontrollably great, it was 5.8. I had to take him for dialysis before intervention. So this is what I was telling about. The first peak should be taken for acceleration time, and this chart one can get it from internet. And so if you have a dome-like one, your peak should be taken. Any first systolic notch should be taken for acceleration time. This point has to be remembered forever, because if even slight adjustment in cursor, it will give a wrong assessment of your acceleration time. So 2 things important. One is the Heiler PSV and acceleration time inside the intraparenchymal, as well as the RIPA, and the visual impression of the Parvus tardus pattern. So this will give a lot of idea. And this is then we subjected for CT angio. It confirmed the diagnosis, and we went ahead with our cardiologist was kind enough to take up this case. But there are people are saying, if you have a kidney on right side, you have to approach from the contralateral side, but our cardiologists are very comfortable with the ipsilateral side. But when we have internal iliac artery, ideally the book description is to go from the opposite side, but our surgeons, our cardiologists are doing from the same side. This approach from the same side, and so just so there is as Pani depicted, there is just a very thin stream was going inside, and we put a stent, and the patient. So this is what the flow afterwards, 5th day. The normal pattern of intraparenchymal flow is there. A good arborization. I call this arborization inside the flow and power. Sometimes, if you really want to know the thing, you can put a power Doppler is a very sensitive. It is not flow directed, and you can always compare with power Doppler. And then the power Doppler, which will pick up even minute flow, it's very sensitive. So both it shows here. So it's a good, and the good arborization is there. And the intraparenchymal flow pattern is also good, nice. Sorry, you see the sound, and you can find out that so this 5th day. So before and after stenting, this is the before and afterwards. And unfortunately, I lost the patient due to pulmosepsis last year, December. So he was traveling somewhere. He got admitted with pneumonia. And then he died of pulmosepsis and multi-organ dysfunction syndrome. So this is about this second case. And this is a 52 years old type 2 diabetes, 6x6 distant related donor, and surgery went uneven full and the graft artery to internal iliac artery. Every month follow-up in 4 months, absolutely was fine. Patient developed press due to very high blood pressure, graft function noted that time. Even after BP control, acute confusional state with he was bedridden for 7 days. Then TRAS was suspected. And this is a case I should give credit to my colleague, Dr. Rajesh. He picked up bruit on this patient in the graft. First time this patient was never undergone any kind of a biopsy and all. So from bruit only we suspected this patient could be having TRAS. So highlight PSC more than 200, strong points towards TRAS. So this patient, we subjected him for a CT angio. It confirmed the diagnosis. We subjected him for same cardiologist did this work, because I want to have a more familiarized with this kind of work, so that more and more work he does, and then we'll be very easy to execute on any difficult patient. So that was my aim. So I give all my patients to one cardiologist. So this is what. So after standing, it's a good result. They're doing fine actually. Within a few minutes, he completed the procedure, and soon after that, his patient was shipped. Only some 15 minutes job he did. So this was the post stenting findings. You see intraparenchymal flow is adequate, and the typical pattern, the eyeball assessment. The moment more and more you see the Doppler pattern, you'll understand you just more rely on your eyeball assessment rather than anything. So this is what. So flow. The first wave is always this one is the first. What we see is the artery. Second is the in a Doppler. The second is a vein. So you put a power Doppler, you can identify. You can trace it also. Because I have a good tracing also, but time limited. I'm going to third case now. This is the ADPKD. Mother was a donor. Is from my colleague Dr. Saranakumar from Pudukkottai. We did a transplant 2.5 months ago. It is an open donor nephrectomy because that facility for a lab was not there. No induction was given, and discharge clearance 1.2. 2 months follow-up, again edema, B blood pressure. Patient became, at the end of 1 month, he was on no antihypertensive. So this time he was put on diuretics and no response. Then one more drug, 3 drugs were added. Graft function noted. Biopsy was done twice. It was ATN. So this is a scenario you should. So when mother donates with the haplo match and only 18 is there, I think this is another point that it should it forces to think in terms of TRAS also. So gradually progress ended in dialysis. So TRAS suspected very late because radiologists did twice, thrice, and they could not pick up any kind of hilar PSV more than 180. So this is very intriguing factor from our point of view. But patient came to us for a group discussion. Then we thought, and based on the our clinical suspicion, we subjected him for a CT, and this was the see, graft looks very normal. But as per the my nephrologist statement that when he was doing the first time biopsy, the color flow was good. Second time it was less. But when we saw, over the days, and the color pattern was going down. Probably, I think that less flow inside the graft. So this was the one, and you see here the TARDIS porous pattern. It's very small. Here the diagnostic point is an intersegmental and porous TARDIS pattern, which claims the diagnosis. We subjected him promptly for a biopsy. This is a biopsy report, absolutely ATM. So we should not cling on to our same suspicion about rejection, other things, and a lot of drug overdose or things. We always think two ways. Only one is a drug toxic, other is a rejection. I think we have to come out of that shell. We have to think a TRAS could be also one possibility. So this is a very difficult, this is a different view actually. And only radiologists could say that it's a tight stenosis. And this is another view. And see, I drew a diagram for this depicting this is the image here. Okay, this is the image of angiogram. I sent it to government hospital where Dr. Molly, one of the vascular surgeon, he could not cannulate the externally a artery into the across the anastomosis. It's a failed attempt from vascular point of view. He said the only surgical solution is the only option for this patient. He attempted, at least he tried for 2 hours, 3 hours, he could not cannulate. So this is a scenario about a failed he may require, but I'm sure this if we subject him for a surgery, I think we will end up in losing this graft. I think probably we have to accept and go whether looking for a further dialysis for lifelong or second option for second transplant. So this is the view. I just not recorded it because it was taken from mobile from the console. So it's not clear. Just I'm skipping this point. So this is the another view I just made here. The another point here. So this is the area where you can see this area was a tight stenotic area, and here and the radiologist is just at the anastomotic site. This is where we fail in PTA. And one of the book recommendation is when you find such kind of a stenotic lesion just at the anastomosis, maybe we may fail many times in PTA. So there's a fourth case. I'll finish very quickly. This is a 39 years old diabetic donor left nephrectomy, short stump. It is only small stump before the bifurcation. So we could compromise while doing anastomosis. This patient present with a discharge creatinine of 0.9. 3.5 months later, we present with anasarca, moderate pleural effusion, relatively preserved urine output initially, later drop resistant diuretics, creatinine worsened by telmisartan. And we thought he was having proteinuria 2+. We thought it's from old, leaking from the old kidney. We were just many drugs. It didn't control the blood pressure. We thought of adding telmisartan here. So creatinine rose from 1.3 to 2.2, 3.8, which made us to think that it could be a TRAS. And patient also was having severe polycation deficiency, low sodium, low potassium, low calcium, low magnesium, except potassium. So all were corrected. We diagnosed a little late. It took about 3 days, 4 days to diagnose it. Patient also had a new onset of moderate to severe mild to moderate pericardial effusion. This is a new finding. Just I should keep in mind whether if this kind of patient present later time in similar cases, I think I should look for pericardial effusion, which may aid in my diagnosis. So this is what they think, and there is a tight stenosis. I know this case because I was involved in the surgery. There is a slight kink at the anastomotic site. We thought over the time it will get relieved, and unfortunately didn't so. See, this is a cut. You can see. Sorry. There is a clear depiction of this thing, and this is I drew a diagram. It's like a kink area where. After the so this is what next one, and so plastic balloon plastic, then stenting, then after that excellent flow. By next day, patient made 6 liters. By another 3 days, he lost 11 kilos weight without any diuretics. BP became normal. He was shifted from one hospital to the another hospital where the transplant was done. Now he's under follow-up. Probably he will be discharged in another 2 days' time. So this is the beauty of the intervention. So this is the post this thing. I just want to give you highlight this point. And here, this was a this anything like a sawtooth appears in the intraparenchymal. This is a before PTA. Nothing looks sinister. Everything looks normal. But if you have eye on this, you will understand based on the clinical findings like anasarca, high blood pressure, all these things will give idea along with this intraparenchymal and the pattern. That's called, we call it an intra. See, the flow pattern is good. If anybody sees for the first time, they will miss that. They will not even think TRAS. But look at I made a round about this area where you see the sawtooth-like appearance. Like, here you measure. It's also normal. But if you go for a Doppler indices, so it's a 168 milliseconds acceleration time, which is the point towards TRAS. So I just go rapidly here. So this is what this is findings afterwards. The 2-3, that is a day for yesterday after stenting, the flow patterns reversed. So he also had a pericardial effusion. You can see here, this is the area, there's a pericardial effusion. Even it didn't subside even after 3 days probably, but it was definitely lesser than what I saw a few days ago. And after stenting, I think the whole diuresis is happening. It's draining all the sodium water retention from the body, and probably he's lost almost 12 kilos now. And this regression of the pericardial effusion also I can witness. So I just go, and this is another thing. 5th case, I'll finish with this very quick. This I borrowed from Dr. Muruganandam Coimbatore. I asked him to present, but he said so he had some commitment. So I just borrowed case details from him and just go through rapidly. So this is the case of 30 days, 35 days. He created from 0.9 to 1.8. So initially he didn't suspect. Then some vague findings were received from the radiologist by the Doppler. So he subjected the patient for CT angio. You see the polar artery. This is what the importance of giving details to the radiologist. So it's a tight stenosis lower polar artery. So this is what after stenting, and what he did amazing work on this. He did 4 biopsies. 10th day biopsy ATN. So 15th day biopsy ATN. ATN was moderate in 50th day. Then he did both pole, upper and lower pole. So whether he just wanted to know whether after revascularization, just a few days after revascularization, it could not be due to revascularization. Any salvageability could happen in this patient. So that's what his curiosity was. So his upper and lower artery has taken. Already lower pole has got a severe IFTA. So this nicely I put it in a very schematic way, and so that one can easily understand even for myself in a future reference. So 26 glomeruli from the lower pole, here 11 glomeruli in the upper pole, none glomerular sclerosis, segmentally none, arteries not represented, arterioles were normal in upper pole, PTC no capillaritis, lower pole 26 glomeruli, glomerular sclerosis 3, and arterioles normal, but arteries have a mild fibrointimal thickening. And overall, his report was that in a lower pole biopsy, IFTA was severe. Both biopsy, it's a 90th day biopsy. So, a summary, TRAS is a treatable cause of refractory hypertension and graft dysfunction. Knowledge about vascular anatomy is vital. So soon after the transplant, as a routine workup, one has to draw a diagram what has happened inside the theater. What was the donor angiogram findings? Everything should, in a nutshell, they should print on the first page of the recipient long-term management protocol that file, so that one can have a quick reference. Anything, because they see TRAS can happen from the day of transplant, but 7th day to even any time patient lives for many years. So this gives a nice reference to both ourselves as to the radiologist and other team members. The treating team must predict the salvageability before intervention. It's a very vital part. PTS have preferred renal treatment. Dual antiplatelets in 6 months, 1 antiplatelet lifelong is the recommended treatment protocol by many studies. With this, I complete. Raj, I'm ready to pick up questions.
Thank you. Thank you, both the speakers, for the illustrative and myriad of presentation. We could learn about the myriad of presentation of TRAS. And to put the thing in a nutshell for the participants, post-transplant hypertension, the prevalence is around 70 to 80% actually, of which TRAS prevalence is around 3 to 20% depending upon the various literatures. The risk factors for the TRAS can be due to the donor and the recipient factors. Donors having diabetes, hypertension, known CAD, while elderly donors are more common risk factors. Similarly, for the recipients, diabetes, hypertension, and presence of coronary artery disease are the risk factors. One important thing which you should not forget is a traction injury of the organ wheel retrieval, of the artery wheel retrieval, that can cause a late onset TRAS from the mid and proximal segment of the graft artery, important TRAS. And regarding the flash pulmonary edema, which we see that is called as a Pickering syndrome, that was firstly identified by Thomas Picker, because of this is a Goldblatt bun clip model where you have a renin-angiotensin axis activation followed by the retention of salts, and which in turn reduces your renin and angiotensin. An increase in volume causes a disruption of the lung capillaries, which along with the diastolic heart failure, acute diastolic heart failure, causing acute flash pulmonary edema. And hyponatremia is more common with the TRAS because of this hypertensive hyponatremic syndrome, because of the pressure natriuresis by the kidneys. And another important thing from the female point of view, there is occurrence of FMD in a TRAS with the distal and more long segment TRAS. When you have to identify, one have to think about the FMD. Actually, there are many case reports where they have an FMD from the donors, which is causing TRAS in the recipients. And with this short nutshell, I'll invite the panelists to comment on the presentations and to ask and give your opinion. Dr. Santosh, your opinion and your experience on TRAS.
Yeah, thank you. Excellent presentations both. I mean, it is really, really well, great, expressed in great detail. This one feature which we need to, I find that is helpful is sometimes the hypertension can be misleadingly not too high. But edema is actually the one feature which I found that if you find edema and it's not explained in a post-transplant, whether it's early or not, you need to get a Doppler. And if the Doppler is, sometimes one of my colleagues was kept telling me, you don't know why he's having edema, and the Doppler radiologists weren't able to pick up a stenosis. So I said, let's just do an MR, and the MRA picked it up actually. So sometimes the Doppler also might occasionally miss it, although we want to look for the RI, and the low RI post stenosis will actually clinch it, like where this said. So I think this is a not too common, but not too uncommon either. And we all need to keep in mind if somebody's got edema or blood pressure suddenly goes up, or if there's graft dysfunction which is unexplained. Yeah, thank you very much. Very good presentations.
Dr. Mahavadi Ekdesa, your experience with the TRAS, I think your center is doing a lot of...
Yeah. Thank you, Rajan. Excellent presentation by Sirapani and Dr. Vel Arvind. So he has illustrated well. We also see we have around now 65 patients who have we have treated, because some people who might have been undiagnosed. So we don't know exactly, but again, it comes to around 1.5% of the transplant renal artery stenosis, if you say the prevalence wise. And it is one of the most important because it's a treatable cause of hypertension. So usual presentation is what we see is in the 6 weeks to 6 months. We have seen initially, it's very difficult for the surgeon to digest. When you have a very early, we have to think it is technical. The first case which we earliest stenting, but Sirapani was saying it is 45 days or 25 days, whether to do it or not. We had, and the first case was flash pulmonary edema. It was doing well, and the 8th day we had to do a stenting. So where we have a very, very difficulty because it's anastomotic, whether we are going to have a rupture of the sutures and whether it's an anastomotic leak. We can keep now, we have coated stents which are available. We can keep them ready and we can go ahead. So it is possible. We have done it on only 8th day. Another lowest, the earliest was in the 14th day. We did 2 biopsies because it's a delayed graft function. 100% matching, brother, and both were young. And patient was having only 500 to 700 ml of output. She was having alkalosis and hypokalemia as typically we see. And she was having a little bit of loose motion. Initially, we thought it could be because of the loose motion. She is getting hypokalemia and alkalosis. That's the reason her output is also good. The first biopsy was an ATN. Second biopsy was an ATN. And then we did an MR, and then which showed renal artery stenosis, and we stented on around 18th day, which she improved like immediately after the transplant, how they pass around 5-6 liters to 7 liters or every 500 ml per hour. So she started passing and then she improved completely. Now she's also maintaining a good graft function. So another patient which is an edema is an important factor. Diabetic person, completed 2 years, he was absolutely normal and renal function was okay. He started having an edema, and this was the only symptoms which picked up. So it's a multifactorial. Is only one presentation is not that, it's a different, and we have to do in our things we usually do before the discharge from the ward, which is in the 10th day. We do it around 6 to 7 days. We get a Doppler done and record it. And then before they go home, usually they stay around 2 months in around Nadia. And during that time, we do before they go, we do it. If there is any graft dysfunction or hypertension, definitely. And every year we do the sonography. So our radiologist, if there is any high velocity, checks and he was tell us. But it's only the initial 6 months are crucial. Most of the cases are in the early 6 months. One patient in 2001, he came from Dr. Pisharadi, where he was unfortunate. It was a very tight stenosis. Just tried to pass a guide wire, it got thrombosed. So the technical failure is also we have to keep in. Then it tried by the cardiologist to do a thrombosuction, infusion of heparin, everything. We could not do anything much.
Thank you, sir. Dr. Narayanan, your comments, please.
Well, I just wanted to ask few things. What was the earliest time, like you have done any stenting, like of these cases? Both the cases which I had seen was around 14 to 17 days. Whether earlier, like post-transplant, the first week or second week, were you able to do a PTA or a stenting in any of these cases?
No, Narayan. Actually, over the years we learned actually, because in the last 5 years only, I really, looked at all these things. I think I would have missed a lot of things in the past my practice. So now I'm suspecting as my third, fourth my DD, differential diagnosis. But I just want to correct everyone, because since I'm involved in the surgical aspect a little bit, so I tell you, as early as 30 days you can go, with the plastic. Nothing will happen.
Okay.
It will not do. But the only thing, and only small balloon, and you should give the size of the renal artery and what stenotic lesions, the segment, whether it's a linear, and what is the stenotic length and all. Then the interventional cardiologist, because that's a routine work for them, no? They have some neocortex to 4 and that kind of perception, they can easily do it nicely. So the volume of case they are doing, I think they are doing amazing work. So I think as early as 30 days you can do, but in my experience, I have not seen anything below. I know it's all 3 months later. 3 months later.
Okay, maybe that is one of the take-home message you should say. Like they should start seeing even the first 30 days. They should start screening.
That's true, but many nephrologists, they're not doing as a routine ultrasound in their OP because they have to depend on somebody. That's why I just want to sensitize this issue, and they have to take up this job as a routine in their practice.
Another important point is Doppler imaging has to be done sequentially, serially. Many times it is mixed in the initial period and it will be picked up in the later Doppler setting. So regular screening of patients with hypertension whom you have a suspicion of DRAS, it has to be repeated so that to pick up this. And also one question to the speakers and panelists, is there any increased incidence of DRAS with surgical techniques like double barreling or internal iliac anastomosis or external iliac anastomosis? Does it make any difference in the incidence of DRAS?
I think one surgeon should be here to answer this. But I think you know very well, because I think we were working together with the one. It all depends on the surgical team, Raj. I think if a good surgeon will avoid all these complications, but it's beyond our control, right? Certain times. But literature says internal iliac artery, it's because we have turbulence and speed and other things, it will produce a lot of sharing effect. So it produces another, I think we do a lot of common barreling, and we do pantaloon pajama technique and interlink. We don't see very often this kind of complication. I think what literature says we are seeing it, but it's not a thing we surgeons creating. But our surgical team is very good. You know very well, right? So probably
Yes, sir.
So it all depends on surgical technique.
A question to Dr. Umavati, sir. What is the incidence of restenosis after successful stenting of this TRAS?
We had only one restenosis which happened. So otherwise, the chance of restenosis is very, very less. Usually what happened is this patient has an atherosclerosis everywhere. He had developed it after that. So you can't say it's a restenosis at the same site because he has a vascular disease. He had underwent amputation, and so he had one bypass surgery and 3 stenting. 2 times he had a cardiac arrest and he was revived. So this person had a pseudo TRAS. So this was the restenosis which happened. Otherwise, we didn't see it significantly. And sometimes in one of the patient who was undergoing a coronary angioplasty, his transplant was also checked again. Everything was normal by an angiogram. So because the vessel wall is very big, reasonably big, the restenosis chances are less as compared to the coronary, which are only 2 millimeters. But again, it can happen. We have seen only one patient.
So what to do in that scenario if you have a restenosis after stenting?
If we need to go it again, and it may be difficult because the neointimal hyperplasia to pass the wire may be difficult. So if possible, we did angioplasty in that patient and restenting, but again, in all times it was not it may not be easy. Okay. We have to judge whether we are doing more harm or benefit, because surgically do anything after 2 years is not possible because of the fibrosis.
Yeah,
nobody wants to dare.
Open surgery is very difficult to do this because of adhesions, everything.
Yes.
Okay. So in the chat box, we have answered the questions of the chat box, and there is one case experience from our colleague like Dr. Rajagopalan regarding the elderly lady in a late post-transplant period who developed beta edema and on multiple drugs on hypertension control with breathing difficulty, who acquired coarctation of intrathoracic descending aorta, and a clinical condition improved after treatment of coarctation. Any similar experience, he was asking. And
we had pseudo renal artery basically in an elderly because the renal artery anastomosis was good. He was having atherosclerosis everywhere. So pseudo renal artery stenosis was there. In one of my colleague had also shared recently, he was also an elderly, that he didn't immediately, the urine output was coming when his BP is more than 150, 160. When his blood pressure drops to 120, urine output reduces. I said, rule out transplant renal artery stenosis. So he did an angio. It was showing an external iliac, which was a problem, and there was a stenosis. They did a stenting and everything improved. So it was acting as a valve. Only the pressure was getting transmitted. One goes above 160.
So the initial management of TRAS, if you are putting in antihypertensive drugs, do you go with the ARB? You will dare enough to put an ARB in the initial?
4 to 6 weeks, we want to stabilize the patient. And then if there is any indication, we go. Otherwise, we don't put a ACE inhibitor ARB so early.
So if we have in a scenario with a double artery, that's a last case, we have a polar artery which is going for a stenosis, which is non for a stenosis. It behaves as of one clip and 2 kidney gallbladder hypertension, that is renin angiotensin mediated hypertension. In that scenario, do you think the ARB or AC inhibitors help in that scenario, where you have 2 arteries, one artery is perfectly normal and another artery is going for a stenosis?
So the perfusion to the lower pole further reduces when you add it. So that will have to take in mind. So if there is a severe IFTA and no recovery possible, and we're not able to stent, then it is yes. So if you have stented already, then you can use it. Sometimes even the post-biopsy aneurysm, that also causes hypertension because it steals the blood from the other areas. There will be more flow through the AV fistula, and that also causes, and it presents as an hypertension.
Thank you. And one question to Dr. Vel Arvind and Dr. Pani. Which patient on TRAS should be medically managed and should not be intervened if picked on routine Doppler, like without any BP change or renal dysfunction?
I think Dr. Vel Arvind alluded to this question earlier. I think if the graft function is decent and hypertension is easy to manage with simple antihypertensives, I may choose not to intervene because in the consequence of intervention, if something goes wrong, like a dissection or catastrophical. So I think it's weighing the risks and the benefits, I guess, and then taking a call.
Thank you.
I completely agree with that, Pani. Okay.
I think the significant
serially follow the patient.
Yeah.
So,
for a significance.
Raj,
Yeah.
there is Adrian is there. Probably think he might have some experience on.
Dr. Adrian, sir, you want to share anything?
Thank you. I have only one case that I'd seen, and I'm just amazed at the presentation. We have not seen it that often, and if I were to even tell my surgeons, "Hey, I think this is renal artery stenosis," they'll be like, "What are you talking about? You have no idea." They take it very personally. But I don't have much. I'm here to learn from you all because you have seen much more than I have. But I also agree. You're talking about renal artery stenosis. I also don't use it. In the first 4 weeks, at least, I stay off of everything. You had another question about, what happens when you have renal artery stenosis in the stent. Yeah, that is a very difficult thing. I don't think a radiologist can go in and even try to re-stent. But now we have, DCB balloons, drug-coated balloons that can prevent reintimal hyperplasia. So maybe that is an option that you have that you can try to see if you can prevent restenosis. That's all I wanted to add.
Thank you, Dr.
Rajan, sir. But again, our surgeons also sometimes, if you say that it's an renal artery stenosis, they take it as an insult, but we have to show them serially the blood pressure is going up, anti-requirement, antihypertensive going up. And we do, for that reason, we do a CT angio before sometimes the intervention. Otherwise, we'll directly go for DSA and then do the stenting. Sometimes we are forced to do the CT angio, show them there is a significant stenosis, and then we go for the angioplasty.
I like Vel's, whenever he comes on, I hone in on his ultrasound skills, and I'm just impressed because I'm learning focus now. We're doing a lot of point of care ultrasound, and we have something known as VEXA scans now. I guess you must have heard of it to check congestion. And so we're learning, and at least I'm learning, and to get this interlobular waveform, spectral waveform, it is so hard. It's not easy. I'm just impressed at the images you're getting. How do you do it, Vel? That's my question.
No, there is a lot of dedications there. Actually, we spend a lot of time. That's why I'm fixed 2 days. We are large volume. We are managing post-transplant. We fix 2 days, Tuesday and Friday, exclusively for those patients. And I see to that. I put my probe on them and see, how the things, and that's where I pick up things with.
It may be that the transplant kidney is more superficial as opposed to the deep kidney.
Not superficial, but it's very tricky sometimes. It's a mimic of, but it's only by experience you'll get to know. But it's a quick learning curve. It's not a big deal at all.
So thank you all. And if there are no further questions, and we shall wind up this program. And once again, I thank the speakers for their excellent presentation, the hard work they put in to prepare the slides and spending the time. And the three panelists who are the stalwarts of nephrologists and who have discussed a lot, and they have taken the time and came here and spent time for us. And the participants, we are close to 80 participants this time. And thank you for the patient hearings and the questions and discussions. And I must thank the MQ team for providing the platform to host our Zoom meet. And the next month, it will be a first Saturday, 8 to 9, as usual. And we hope that you'll be joining, and we invite many centers to present interesting cases so that we can learn from all. Today is the day of transplant renal artery stenosis, and with take-home messages of many presentations of TRAS and management of TRAS. And we are very much heart-filled with the academics this time. Thank you all for the wonderful joining meeting. Thank you.
Thank you.
I have a question. Thank you all. I have a question, Raj. Is this recorded? Where can we access this recording?
Actually, we'll be posting in, we have a recording, we'll be posting in at YouTube, sir.
15 to 20 days, it'll be available.
What's the address? you have the YouTube address to give it to us so we can read.
Oh, sir, don't worry. We'll put in our WhatsApp forum. We will just display that link. Don't worry.
Okay. All right. Perfect.
Thank you. Sir.
Thank you.
Thank you.
Thank you. Sir.
Thank you. Thank you, sir.
Thank you. Good night.
Thank you. Thank you, sir.
Thank you,
Sir.
Thank you,
Thank you,
thank you, Raj.
Yeah, sir.
Thank you, sir.
Sir.
Thank you, sir. Thank you, sir.
Umapati, good night.
Sir, thank you, sir. Good night, sir.
Thank you very much. Good night. It was very, very well managed, and thank you.
Thank you, sir.
Raj, good night.